Shubham ji, I am Mohammad Ali Ibrahim. I'll be your host for the next panel. Um, I think we need to give a further round of applause for some of the frontline heroes. I think the applause did not do justice, please. So I have a very exciting panel, and where we will be basically setting the tone for what the discussions would look like for throughout the year, for throughout the day. So we talk about healthcare challenges. Where are we today? What are some of the pressing challenges that we see? What are some of the opportunities? And what do we take from there and now take forward? So please join me in welcoming my esteemed panel, Professor Bashir Hanif. He's a leading cardiologist. Professor Najmul Islam. Professor Amrita Tasneem Ehsan. And Professor Abdul Wase, Professor Ahmed Fawad. Thank you. So I believe while you already heard Dr. Shahzad set the context that as a developing nation, we do have some challenges where in a country where nearly 2 to 3% of the GDP is being spent on healthcare facilities and with a population of 220 million plus, so healthcare challenges are abound. So with higher rates of poverty, low literacy rates, overpopulated cities, low socioeconomic challenges, there's a lot that we need to address. So just to state some quick facts to frame Pakistan's healthcare situation more clearly, the overall burden of death, BOD, for Pakistan in 2019, as measured by the Disabilities Adjusted Life years, which is the sum of the years of lost life to premature death and years lived with disability, was almost 42,000 dailies per 100,000 population, only lower than Afghanistan and higher than Yemen and Iraq. Life expectancy is almost 66 years. Child mortality under 5 is 65 per 1,000 live births, and the doctor to population ratio is estimated at 1 doctor for nearly 1764 people. So without further ado, I would like to start with my doctor. Sir, you know that there are a lot of challenges. What, in your opinion, what are some of the key, let's say, 3 biggest challenges facing Pakistan's healthcare system at the moment?
I'd like to focus on what is in Pakistan and what is needed to change. In Pakistan, we certainly are way behind. Probably we made a bit of progress during this COVID period because of the necessity and a lot of digitization of healthcare took place. Let me make one thing clear. If we are wanting technology to be accepted across the board, just think what made technology change that, pardon my statement, today even a monkey can use technology. Think about it. I think it was the user-friendly interface which was promoted by Steve Jobs as the iPhone, which changed the face of usage of technology. Now, why did this happen? It is very relevant to healthcare. Today, all the healthcare things that we are creating are based on keyboards. Now, I am not a good typewriter guy. You ask me to type, I'll be horrible. I'll be making too many mistakes, and I'll be too slow. If I am doing that, my contact with my patient is lost. So unless and until a user interface which is friendly can be used by the doctor or by the patient equally is created, the implementation of healthcare, of digitalization into healthcare will be limited. That's one. The second thing is, if there is no money, then whatever we are talking out here is a pipe dream, and that's true. Where does the money come from? Health insurance is probably one of the needs, and that's why I say in the survey that we were given earlier, I've put that on top as health insurance. You have money, then all your thoughts, whatever you have, can be translated. So at the end of that, what you need is the patient has to be the focus. With technology, you should not be lost on your keyboard. You should be looking at your patient, and you should not lose the contact with the patient. If we can find such solutions, I'm sure digitization in Pakistan will take a leap. Thank you.
Okay, thank you. Maybe if I can take the, just a follow-up of what Professor Saab said to Professor Tasneem. Uh, he spoke about, yes, there is a requirement of technology, but maybe we can take a step back and say that, okay, if the technology is there, not there. So what, in your opinion, are some of the basic steps that need to be taken to solve some of the critical challenges that currently we face? If, let's say, technology is not there for a moment, if you take technology out of the question, what are some of the basic steps that we need to take in terms of addressing the core health challenges?
Challenges without technology. If there was no technology, what kind of challenges you would?
Okay, I think the challenges in healthcare without technology is something that everybody is aware of. And it's the inequality, inequity in terms of what people can afford, because there isn't, at least in most of the country at this point in time, a uniform healthcare or health cover for everybody like the kind you have in NHS. So it is dependent on what you can afford and the public healthcare system. But mind you, having said that, I've had some experience of looking at the American healthcare system. And I can tell you without any doubt that some of what we offer in our public healthcare is way better than what is possible in the US. So having said that, I do not want to imagine a world without technology, because we are at this point in human existence. And as a medical professional, not just as a doctor, but as a teacher, we were aware of Zoom, but we weren't using it. We were forced to use it because of the pandemic. And now it has become so routine and usual that it's a bit irritating to have to go to a meeting, travel to it, and do what has to be done. So we are all completely on board with regards to our teaching and training sessions with remote possibilities, with go-to meetings or Zoom or whatever. And we didn't know how to use it. We very quickly got on board and had to learn, taught each other, and did it. So in terms, the same applied to patients. We were never doing any remote consultations with them. So we were forced to do that also. And we do have some idea about what are the deficiencies, you know. Not everything can be handled on a phone, but just to know what can and can't be handled on the phone. And we could very easily draw up a list of, you know, questions or presentations that have to be seen in person, and the rest and a lot can be done remotely. I don't agree with the thing that, you know, in-person contact. It's the quality of interaction. But what I miss in that remote interaction in looking after patients is not having the data about the patient. So if we had data of who we were talking to, what is the background story, what is the current problem, what medication they're on, it would be a very effective interaction between the doctor and the patient, or pharmacist and the patient, or whatever healthcare provider. So I do not want to imagine a future without technology, because that's not what's going to happen. We better realize that this is our reality, and we better try and do it better and quicker. Thank you.
No, thank you, absolutely. And there is no denying that technology is a great equalizer, and the earlier that we adopt and adapt our healthcare systems, the better we can address some of the challenges. Moving on to Dr. Bashir. Sir, I believe you mentioned that you recently came back from the US. One of the challenges that have been mentioned in the survey that was administered before the Health Summit, that people have spoken about a lot of brain drain. There are a lot of qualified doctors have gone outside Pakistan. So that is one of the things that is currently also at challenge for the Pakistani health industry, that we do not have qualified practitioners to serve the public. What is your take on that?
Thank you very much. I think this problem is true for every industry. There is a lot of brain drain, not only healthcare industry, but other fields as well. And healthcare industry is particular. Just to give you some example, I graduated from AKU in 1991, and my class, there were like 100, close to 100 graduates. And right now, out of those 100, there are only 5 who came back or who stayed in Pakistan. 95 are still in US or somewhere else practicing there and don't want to come. There are several reasons for that, and I have faced myself. I moved back after staying in US for almost like 12 years. And when I wanted to come back, there was so unwelcoming attitude from everyone over here. I can tell you, I met several people and everyone was negative that you don't need to come back. Literally, someone told me कि यहाँ आएंगे तो कीचड़ में छलांग लगाने वाली बात है. It's better आप वहीं पे अपनी जो है वो practice करते रहो, आने की ज़रूरत नहीं है. तो एक तो ये है कि थोड़ा सा this is one of the problems from like maybe colleagues or your healthcare industry. Not everyone is like that, but there are people who don't want to do that. But the second major problem is like the opportunities are very limited. Okay, if I am established working in US with a very good practice, and here I come back and start from zero, and it's not going to be easy. I have to be mentally prepared. I came back. I basically was the first employee started at Taba Heart Institute, and it was a daunting task to start a new institute or establish the systems and do something. And people who are there, it's very difficult for them to leave a very cozy environment, very well-established practice and come back and start from all over again when there is no support from anyone. There is a lot of, initially, I'm sorry to say again, not all, but there's a lot of animosity from even your own colleagues as well. And there is no support from government as well. I can tell you, we have a group of people who came back from US, it's around 150 or 200, and all of them are settled now in different parts of the country. And at their level, everyone has done really great, and some of us are actually helping still working here or basically in different organizations back in wherever we came from, including myself. But when we try to approach government here to try to see if we can help in any way, unfortunately, it's totally no response from them and totally unwelcoming attitude. I have been to like our health ministry several times, met health ministers several times, given them several like suggestions and try to see how can we help all of us together, but nothing has happened. So there are several issues. It's not only, I would say, partially obviously the fear of unknown when I come back, and I had the same thing, and everyone has the same. I have a lot of colleagues who say, I want to come back, but when they ask where should I come and what should I do, and I tell them that you have to work hard in the beginning, and you have to have your expectations very low in the beginning, but gradually it takes time. They want the same kind of success as overnight as it was over there, which is not going to happen. So there is a partly on our, like, there is a resistance in us also, or those who are like out of country have gone there and working there. But then again, as I said, there's a lot of problems over here from government level as well as the health industry from here, which need to overcome. There should be somebody who should be able to help them to settle. Everyone is looking for a job in a very good institute with all the facilities and great compensation, but that doesn't happen overnight. When they ask me, how do I feel after 15 years being here? And I tell them, I was in US for 12 years, I can tell you, the professional satisfaction, you have it working in your own country. There's no match to that. What I got in like 1 month, I did not had that kind of feeling or professional satisfaction in 12 years back in US. So those kind of things are really, I think, I keep telling them, and what I've been able to do or achieve, it's like I could not have done over there in whatever time I have stayed there. It's a routine practice, go there in the morning, come back in the evening. But what you can contribute and do back home, it's like unbelievable.
Jana, thank you, sir. I believe, yeah, thank you. So I believe one of the issues that he mentioned was the mindset when people come back. So yes, the welcoming attitude and everything that needs to be further looked into. So before I move on to Dr. Islam, just like to want to remind you that the Slido app is open. Please record your entries. People who have logged in virtually, There are a lot of interesting insights coming in, so please send in your comments. We'd like to ask our esteemed panel of judges. Dr. Islam, you've also worked quite extensively, and of course, आज हम health summit में बैठे हुए हैं, and we're going to be talking much more about the use of technology कि हम उसको बेहतर से बेहतर बना सकते हैं. And I think जो डॉक्टर शाहिद साहब ने भी कहा कि जो हमारी जो memory है, if we mostly we are more tuned कि हाँ भी जो हमारी short lived memory होती है उस पर हम ज़्यादा depend करते हैं. And I believe the way that Pakistan was recognized for its efforts to deal with the COVID, and primarily one of the reasons was the use of technology. टेक्नोलॉजीज़ के तहत आपने किस तरह से रैपिड टेस्टिंग अपनी की, किस तरह से आपने कोविड हॉटस्पॉट्स आइडेंटिफाई किए, किस तरह से आपने वैक्सीनेशन ड्राइव्स की, तो आपकी कंट्री में स्मार्ट लॉकडाउन्स लिखे टेक्नोलॉजी. सो व्हाट इज़ योर करंट टेक कि अगर हम टेक्नोलॉजी को मज़ीद इस्तेमाल करें, सो व्हाट आर सम ऑफ द अदर एरियाज वेयर टेक्नोलॉजी कैन बी वेरी वेरी बेनिफिशियल गोइंग फॉरवर्ड?
Bismillahirrahmanirrahim. Your questions about how technology can be used for a patient's benefit really is very important, and we have learned really during this COVID pandemic as well in Pakistan, because I work in AKU and there was no telemedicine there, and during the COVID we started with the telemedicine. So telemedicine started, we started to learn, but there are hurdles to it. The internet access is not there all over Pakistan. The proper portals have not been developed. But if those things are streamlined, really, we can have a good access to the patient from remote places as well. But obviously, telemedicine cannot replace altogether because the physical contact is also important. I don't say that physical contact is important at every visit, but at least initial visit, physical contact is important, and subsequently, certain follow-ups can be done on telemedicine. So I think telemedicine is going to grow with time in Pakistan, and it is going to improve the healthcare, access of healthcare to the patients. But obviously that needs work at different levels, at the hospital, at the level of government, at the level of telecommunications, because if internet is not there, telemedicine will not work, even if you have good telemedicine at your primary site. So those are the things, and I am a great believer that this is going to happen, but presently the situation is not that good, and I think a lot of work is required.
So just on that, you said that telemedicine, yes, it is important, and there's no saying that physical consultancy is not important. Or let's say internet bhi hai, technology bhi hai, and I'm sure there are a lot of cases that I've at least come, and I'm sure the people over here would also know about them, कि कई दफ़ा ऐसे incidents हुए where people were looking for first aid emergency treatment and all, but in some of the rural parts of Pakistan, but the first hospital was quite a few hundred kilometers away from that rural city. तो एक आप मुझे ये बताइए कि is internet connectivity the only solution, or is there any other systemic thing that also needs to be highlighted at this forum कि to make telemedicine more proactive, कि at least के जो first aid की जब बात करते हैं तो जो चाहे अगर वो trained doctor available नहीं था, but at least जो आपके first life जो staff होता है उनको अगर आप telemedicine के through या उनको बता सकें कि किस तरह से आपने एक patient को revive करना है, ताकि वो जो एक था कि instead of a person losing his life on the way, you can at least have some kind of efforts made in through the use of technology.
Definitely, different things can be used really to improve the healthcare. For example, if internet is not there, but again, if we teach our healthcare professionals, the paramedics and the nurses, about how to take care of the patients initially, before they have an access to us, if we develop that sort of training to them, that obviously can be provided to the patient at the beginning before they have an access to us. So I think work can be done on that site as well, and that will definitely have an improvement in the healthcare.
Sure. Professor साहब आप कुछ कहना चाह रहे थे?
Certainly. दो चीज़ें, एक तो आपने excuse me, इमरजेंसी की बात की. डिपेंड करता है कि क्या इमरजेंसी थी. अगर सिर्फ सर दर्द था या पेट में दर्द था तो probably an analgesic is what can be advised from a distance. But if there was some serious emergency, then that patient needs to be with some health facility or with somebody who has some knowledge. So I think let's get that gray area out. We think that everything can be solved in an emergency situation. डॉक्टर साहब का जो एक सजेशन है कि जो एक ज़माने में अमन एम्बुलेंस वालों ने यहाँ पे शुरू किया था कि और फिर वो और वो बल्कि पंजाब ने पहले शुरू किया था 1112 जो है कि दे हैड हाईली ट्रेंड क्या नाम है paramedics who were driving the ambulance with a junior doctor who was along with that trained in emergency care, and they were the first responders to that. So that still remains to be an important thing. But the point I was trying to come to was, जो आपने एक सवाल किया था कि how else other technologies can be used for telemedicine. Now let me give you an example of one of the physicians who's using WhatsApp very effectively with no software loaded on that, just simple WhatsApp. And the procedure is that a patient makes an appointment, he calls the PA to make an appointment who would take the details. He has already a WhatsApp जो ऑटोमेटेड मैसेज है कि जब आपको वो आता है तो एक ऑटोमेटेड मैसेज आ जाता है जिसमें आपको टाइम आ जाएगा, ये जो डिटेल्स हैं अपनी, ये आप वो स्कैन करके जो है वो भेज दीजिए. और अगर पेमेंट का कोई सिलसिला है, दैट पेमेंट वाज बीइंग डन थ्रू इजी पैसा, through Jazz Cash and all these other banking tools, digital tools, the consultation was being done. Then the patient came face to face with the doctor on WhatsApp video. By that time, through the PA, the details of that patient was already with the physician. So the physician had something like a tablet and a camera with the WhatsApp going on or there. So he had transferred all that onto his tablet so that reading was easier. At the end of the consultation, he would write a physical prescription, take a picture of that, and send that to the patient. So the patient had a copy of a physical prescription which will be utilized to show to anybody for the medicines that they would be requiring, and there would be a proper digital documentation of that. So that was one aspect of that. The other point that was touched earlier was about pharmacies. Now, there are two ways to look at pharmacies. जो statistics बताई थी शहजाद साहब ने कि pharmacist की जो the lowest जो proportion है हमारे मुल्क में pharmacist का है. But if you look on the other hand, the biggest business that you have is the medicine of selling drugs. And that is not by pharmacists, that is by a dukandar. So a dukandar is selling drugs and there is no regulations. When it comes down to medicine, the PMDC or PMC or whatever have come down very heavily on the necks of the doctors कि आप ये कर सकते हैं, ये नहीं कर सकते हैं, and so on and so forth. But a huge big thing where you can buy any medicine, कोई restriction ही नहीं है prescription की, आप हर medicine just walk across and buy that. And that is, I think, a very major thing which will be looked into if we want to digitize. वो जो एक दिखाया था इसमें कि वो दवाई जो है वो online आ रही है, वो ये दुकानदार से नहीं आ सकती ऑनलाइन, बिकॉज ये दुकानदार के पास एरर की बहुत गुंजाइश है. दैट हैज़ टू कम थ्रू अ प्रॉपर फार्मेसी. सो अनलेस एंड अंटिल वी रेगुलेट द फार्मेसी in a proper way, and that's integrated into healthcare, you can't achieve across the board digitization.
Thank you, sir.
Yeah, I think very good points discussed, but just like everything else, technology has also pros and cons also. I can understand doing all those things on WhatsApp, but there are certain conditions you can't really tell without examining the patient. And again, our legal system is also becoming very active, just like it is in US. US, there is very limited use of telemedicine because of the legal issues. Because if I, based on the history, I give the whole prescription to someone and something happens to that, I will be responsible. So the legal system has to cover that as well. It's not that you just do everything on, and if certain things you can, maybe some emergency, maybe you'll be able to handle, or you're able to advise them, go there or do this and that. But I think completely relying on technology, that becomes a problem too. I still practice in US off and on, and I can tell you earlier you were mentioning, and I can't agree more with that you cannot completely rely on the technology and completely lose the touch with the patients. What's happening right now over there, if I see a patient, there is so much documentation on the technology in the computer that your eye-to-eye contact with the patients is only maybe for a minute. Rest of the time, maybe whatever 5-10 minutes you have, you are spending on the computer and writing everything and documenting everything. But that does not really satisfy the patient all the time. And again, I have kind of a little bit different experience. I got stuck in US during last COVID, and I was doing my clinics online. And a lot of my patients really weren't satisfied until unless I am able to talk to them directly, I am physically examining them, and they said, "Doctor साहब, हमें जैसे आप वापस आते हैं दोबारा appointment दें, हम आके दोबारा दिखाना चाहेंगे." So these kind of issues are going to be there.
Professor Tasneem, आपसे मुझे question, आपने one in your previous note you said your aspiration would be कि मेरे पास patient data available हो, so that will really help my life easier. A question आया है, so from one of our people joining virtually, he or she said, if I have some symptoms, I'm not so sure to which specialist I should consult with every time because I have to go around in circles, वहाँ एक GP से दूसरी GP, दूसरी GP से. So जब आप बात करती हैं कि if I have patient data and if that patient, let's say, is coming from multiple doctors, from multiple hospitals, how would you ensure the authenticity कि वो जो patient की recording जो हो रही है वो किस तरह से हो रही है? Maybe in a hospital where you have SOPs in place, जो let's say अगर वो कोई patient आता है from in a hospital तो वहाँ पर शायद हो सकता है uniformity हो. But let's say if people are coming in, walking in, and they've already visited other people, so they do not know कि हमने अभी भी symptoms हो रहे हैं, हमने किसके पास जाना है, किसको हमें treatment मिलेगी timely वगैरह. Even in the let's say there is technology available कि हाँ भी वहाँ पर कुछ data वगैरह already recorded है.
So obviously यहाँ पे तो चूँकि इतना disorganized system है, people basically just pick who they want to go to. There isn't like a catchment area or anything like that. So people go to the doctors they want to go to. How do they find out who to go to? I often see there is, for instance, a DHA Facebook group. And somebody will post a question, who's a good pulmonologist or cardiologist, and then you see a string of names appearing there, and some with addresses and all of that. So people have different ways of, and there are apps also, which by the way, I don't want to name it, but they put your data, like doctors' data, without their permission, and it is inaccurate data. So that is very unethical. I mean, if you've got an app going or a business going, you have no business putting my data. I'm not saying those things about myself, and you have it there without my permission. I very recently threatened legal action and had my name removed from one of these apps. So these apps could be useful. It could list the number of cardiologists and their areas of practice, but it has to be done with their consent. They can't just be on their system. So एक तो ये कि doctors की information patients को कहाँ से मिलेगी? So if you have an app, and I'm sure it won't be one app because there are so many players in this field now, there can be so many different platforms जिस पे लोग जाके देख रहे होंगे. But आप जिस doctor की भी information अपने platform पे डालते हैं, you have to make sure that you have that doctor's consent. And the information you put out there is also something which is correct. And sometimes when you look at people's, I'm talking about doctors now, the information they put out there about themselves is so wrong, specialist of this and specialist of that. And so people who were in hiding during COVID, emerged in the second and third wave as the COVID specialists. And and online consultations at huge consultation fee, and working as people as COVID specialists. So there's a pinch of salt to be taken from there. Even what doctors themselves project themselves as, and I don't know who's going to regulate that. As regards the patient, when we say, I've done these WhatsApp consultations in pretty much the same way like Dr. Fawad described, but I could not rely on my PA to get medical information. I was using my junior doctors to first take the whole history, generate a record in the clinic, so that by the time I have that face-to-face, my junior doctor had at length discussion with the patient, had a table of their medications. And the patients were very happy because it wasn't a PA they were talking to, it was a doctor they were talking to. Or sometimes if you have a trained nurse in a very focused area of work, like in some specialties, a trained nurse could do this as well. But I don't see an appointment clerk doing this for you. दूसरी चीज़ ये भी है patient when it's on an app, safety of information of patient data. And there are some things that are very truly confidential between the doctor and that patient, you know. How does that happen? उसकी ease का भी ख्याल करना होगा. So there are many of these things, and I think we're on a learning curve for everybody. And like Dr. Bashir Hanif said, if we have to spend so much time on the actual typing and all of that, this is a time that you lose in terms of your direct patient interaction. And patients don't like it one bit.
Let me add to the answer to your question, really. I mean, your question, whom should the patient consult really for a problem? But for that, we should have a structure of a primary, secondary, and a tertiary healthcare. So a patient should consult the primary healthcare first. They should be seeing the patients, may it be physical or through telemedicine, and then they have to see whether they can sort it out at their level, or they have to refer it to a specialist at secondary or a tertiary level, so depending upon the problem. So that's how things should be.
So we are almost out of time. Just to close the discussions, Professor साहब, ये point आपने raise तो किया, लेकिन हमारी society में ये भी देखा जाता है कि जब तक कि तबीयत बहुत ज़्यादा ख़राब नहीं होती हम लोग जाते ही नहीं डॉक्टर. वी डू नॉट हैव दैट काइंड ऑफ रूटीन कि भाई चले साल में एक दफ़ा 6 महीने बाद जाकर अपना एक चेकअप करा लें रूटीन में, जस्ट टू सी कि हाउ आर वी डूइंग एज अ ह्यूमन, हमारी जो भी ऑर्गन्स वगैरह हैं. वी डू नॉट हैव दैट. जब एकदम लास्ट मिनट पे जब सारी चीज़ें होती हैं उस टाइम फिर बहुत ज़्यादा वो एफर्ट्स पुट इन हो रही होती हैं, जल्दबाजी भी होती है, एंड देन इफ यू आर नॉट एबल टू, तो हाउ कैन यू ऑल्सो एड्रेस दिस एलिमेंट एज वेल कि हमने माइंडसेट भी चेंज करना है कि भाई दिस हैज़ टू बी, जो प्रिवेंटिव हेल्थ केयर की बात हो रही है कि अगर टाइमली अगर हम जाएँ और लोगों अपनी चेकअप वगैरह कराएं, सो मे बी वी वुड नॉट हैव टू रीच आउट टू ऑन दोज इमरजेंसी सिचुएशन ऑल द टाइम.
Yes, I definitely agree with you that we have to change our mindset and we should take care of our health.
और उसमें I think I believe you will already have that kind of repository of your information being generated right from, let's say, whenever you start with those routine consultation कि भी आपने जब गए तो आपकी क्या क्या health care vitals वगैरह थे, सारा कुछ आपके पास आ रहा होगा.
जी, definitely.
Okay. Thank you so much. We're always struggling with time. I hope you enjoyed the proceeding of the first discussion. काफ़ी चीज़ें ऐसी थी जो मैं पूछना चाह रहा था. There were a lot of interesting comments and questions coming in, but I believe the panel members would be here during the break time. Feel free to reach out to them. Thank you once again for your kind patience. Can I just request you? We have some shields available. एक मिनट प्लीज़ अगर आप लोग एक मिनट रुकें. So can I please request Mohammed Akram, Commercial Director for CCL Pharmaceuticals, to come on stage to give a shield to our fellow panel members, please. Thank you. And also share a few words.
Thank you, Pin. I'm especially thankful for the esteemed panelists sparing time. They are very busy people and they spare time for this discussion. I think these are some enlightening things which can be a starting point at least to enforce or to start something like digital healthcare in Pakistan, and this will go a long way. Certainly we can't miss the touch with the patient. I have seen, being pharma professional myself, that patients are not satisfied until unless doctor touch them and see them physically. So we also tried our best to promote digital healthcare in the time of COVID. We also launched an application, our application, with the name of Mover. But patients were reluctant. Doctors were seeing their patient through the app. So this is a long way to go. But thank you very much again for your contribution to the cause. Thank you very much.
So if I can please request the shields, please. So we can start. आइए प्रोफेसर में प्रोफेसर आप प्लीज़ आइए. सॉरी पहले कौन बशीर साहब सब आइए. नेक्स्ट वन प्रोफेसर नहीं प्रोफेसर नजमुल इस्लाम प्लीज़. आई बिलीव ही इज नॉट हियर. Professor Emerita Tasneem. Professor Ahmed Fawasa, please. Thank you. A round of applause, please.